Welcome to Pushing the Limits, the show that helps you reach your full potential, with your host, Lisa Tamati. Brought to you by lisatamati.com.
Everyone, welcome back to Pushing the Limits. This week, I have my favorite doctor, Dr. Elizabeth Yurth. Now, Dr. Elizabeth Yurth is from the Boulder Longevity Institute in Colorado in the USA. She is a longevity expert. She is also an orthopedic surgeon, an orthopedic specialist, and today's topic is arthritis and everything around arthritis. And arthritis is a disease process. This is a really new way of looking at arthritis, and you're going to find a whole lot of value in this. Everyone, welcome back to Pushing the Limits. This week I have my favorite doctor on earth, Dr. Yurth. Welcome to the show, and I'm already rhyming poems this morning. How you doing?
Lisa. My favorite podcaster.
You had to say that, didn't you?
And human being.
Today, I don't know how many times you've been on this podcast, but you're really absolutely fantastic, and you're looking after my mum, so what's not to love? Today's topic, though, is one that will interest a whole lot of athletes out there, I think, and also just people that are dealing with arthritis. So arthritis is the theme of the day. And actually, even though it's about arthritis, this ties back into all the big diseases, which is really what I'm interested in digging into. So, Dr. Yurth, we have this sort of perception as the lay public, if I can speak for the rest of the world, that arthritis comes from when you have an injury and you start to break the cartilage down, or the joint gets worn down, and it's a wear and tear disease. Why is that not quite the full story?
So it's really a huge misconception and understanding of arthritis. And it's funny because we wouldn't think of dementia as you used your brain too much and you wore out your brain, nor would we think about heart disease as, wow, your heart beat too many times, so you wore out your heart. And yet somehow we think about our joints wearing out as, oh, you just used your joints too much. And it's funny, I was talking actually to my yoga instructor who needs a hip replacement, and she was saying, yeah, it's just signs of a life well lived. And I was thinking, no, it's not. And so just like what we're becoming more aware of is that this is an inflammatory disease process, just like brain disease, cardiovascular disease, metabolic disease. It's all part of that what we term inflammaging, a disruption in our immune system that leads to a destruction of tissue. And whether that tissue is your heart or your brain or your joints, it's all the same reactive problem, which is your immune system goes haywire. Mm-hmm. So, and you're right that this starts with those little injuries, right? So we know, for instance, that if you tear your ACL, I tore my first ACL when I was 16, 17 years old. If you tear your ACL, your likelihood of developing arthritis is 80% by the time you're 50. Wow. So it's really high. And that's if you did surgery and we think, okay, it's all fixed, you're good as new. Not. So we know that process starts even when we're young and we have these little injuries. Or, somebody like you who you think, okay, well, I just put so much wear and tear on my joints. Well, every time you're running, right? Every time you're putting that load on your joint, there's this inflammatory process going on. And our body's designed to get this inflammation and start healing the joint, right? Mm-hmm. That's a normal response. The problem is when that inflammation stays up, and so we get this imbalance of these pro-inflammatory reactions without the secondary step, which is the anti-inflammatory or healing stage. So it's the same thing, right, that goes on with COVID, right? Mm-hmm. Yep. So why do some people die of COVID? It's usually not, the virus itself, it's the immune reaction to the virus. Yeah. So people develop this what we call cytokine storm, right? They get the COVID virus, and some people get rid of the virus and they're fine. And other people, and we're seeing this with the COVID long haulers too, right? Other people instead mount this big, huge immune response. And that immune response starts attacking your blood vessels and your heart and your kidneys. So it's the immune response to the virus that sets off this cascade of reactions that ultimately kills you or creates long COVID, the COVID long haulers. It's the immune reaction, to this virus. And so the same thing happens with these joints. It's our immune systems overreacting to injury that now starts to degrade the cartilage. So, that's why what we're doing isn't working. Why,
because that's what I wanted to dig into. So this is an inflammation or inflammaging process, and this can happen even with young people. I mean, I'm dealing with a young man at the moment, an athlete, got very, very young, major issues. So it's not just a disease of old people. It is partly genetic, partly environmental, partly injury, and then this disease process that happens. So why is this sort of similar to the things like heart disease and, all of these neurodegenerative diseases, heart disease, all these things have that one thing in common, as you said, an increase in the pro-inflammatory cytokines, chemokines, all of those ILs. I can't even remember all the ILs, IL6s and 1s and 15s and 18s or whatever they all are. All of those things go up. Why in the healthy person? So like I've run, 70 or more than 70,000 kilometers, and I don't have arthritis. And I had a very bad back injury and I had arthritis in the back, but I have no pain now in the back. Why is that? When you would consider that, someone with no discs left and 4 of their, things, I should be in pain all the time. And I used to be. Why am I not now? Why am I know sort of why I'm sort of getting to the point of, okay, I've got less inflammation in my body going on because I know, because I've been learning from people like you. Why have I not got the pain that I used to have? What's actually going on there?
So you're exactly you're exactly right. When you say this is a conglomerate effect, basically, if you have, perfect genetics, so there are some people who can even live life poorly, right, and have perfect genetics. Most of us don't. So, it is a combination of genetics and environmental factors, and then those things propagated by trauma. So, I like you. So I tore my first ACL at 16, tore another one. I've had 4 ACL reconstructions. I have end stage arthritis in my knees. My knees have no cartilage left in them, but I have no pain, right? I have, my knees are not particularly stable. I have to brace them for, doing things like skiing, but I don't have any pain in them because I've gotten my inflammation under control. So much like you with your degenerative discs, we know that degeneration in and of itself is not the cause of pain. It's the inflammation. So what happens when the body suffers an injury is you do get very high levels of things like tumor necrosis factor alpha, interleukin-1, interleukin-6, interferons, things like that get elevated. And then that sets off, this response to healing. Now, the next step should be really within, a few days, those go down and we start seeing these anti-inflammatory proteins like interleukin-4, interleukin-10, things like that come into play. So now, the balance goes from this to this, and we can heal and recover. If it stays here, the next step is you start seeing damage to the cartilage cells.
Right.
Now, go back to the same thing that happens with heart disease or, brain disease. The same thing that, maybe you have this underlying genetic piece, and then you're eating a little bit of a poor diet, or you're doing something that's not quite right, and you set off this inflammatory cascade. So what's the next step to all this stuff? Well, what we know happens next is that these damaged cells, whether it be in your heart or your joint, create that. Remember, we've all talked about that senescent cell.
Yes.
Basically the injured cell and what it does. So what we know happens in joints or in your heart or in your brain is this in the joints called chondrosenescence. So the cartilage cells are damaged. And instead of, again, we're going to go back to when cells are damaged and they get old and have too much trash accumulated in them, what they should do is kill themselves off. That's the autophagy piece, right? When that's disturbed, those damaged cells create proteins that start damaging themselves, other cells. So now it's why when you get a little tiny injury, all of a sudden it'll start propagating. Like you'll see somebody have a little injury to their joint, and then 3 months later you re-image the joint, and it's like worse, and 3 months later worse. And it's not as though you're continuing trauma. It's that basically these damaged cells beget damage. So they start spewing out these proteins. So we call them zombie cells. These senescent cells are called zombies, right? Because they spew out these proteins that damage the cells around them. So we know that there's a lot of pieces that go awry. Basically, too much inflammatory cytokines, based on genetics a lot, but also environmental influences, diet, right? Those are all things that play a role.
Toxins,
toxic exposures, right? So again, if you had perfect genetics, you could probably fight off all that stuff. But since most of us don't, now you've got these environmental exposures. So first thing, we have these high inflammatory cytokines. Second thing, we start getting cell damage. So we basically have senescent cells. Third thing is we lack autophagy. And so now we're linking this lack of autophagy or getting rid of damage as a big piece to arthritis as well as other diseases, right? So if we look at where we failed in treating this problem, so let's look at the traditional treatments. Okay, so number one, you go in. So first of all, let's start with that first injury in my 16-year-old. Instead of just doing surgery and sending them on their way, should I be really focusing on, okay, I did surgery and I repaired your ligament. Now let's make sure you heal appropriately. So we need to turn off those inflammatory proteins at some point. So we can use simple supplements to do that. You know, things like epigallocatechins, what's in green tea. So you can use some, curcumin, things like that, simple supplements to turn down that inflammatory response so that the person heals more appropriately. So in our patients, when we have a young person who has an injury, we get very aggressive in utilizing an approach so that they don't start that cascade right then to having arthritis when they're my age, right? So that's number one. You've got to turn off these pro-inflammatory cytokines, whether it be in that young person or in somebody my age who's presenting with inflammatory joint pain, or you with your disc disease, which are frankly the same disease, whether it's degenerative disc or degenerative joint. It just depends on what part of the body seems to get more attacked. But so we've got to turn down these inflammatory cytokines. Second, what we have to do is we've got to get rid of the damage. So you have to induce autophagy.
Autophagy.
Right?
Can you remind everybody what autophagy is? Knocking off the damaged cells.
The damaged cells, exactly. It's self-death. So basically autophagy means self-eating, autophagy, self-eating. So what cells are designed to do is when they accumulate a certain amount of damage, so you have these nice young healthy cells, and then they start going through cell processes, oxidative phosphorylation, and start accumulating damage. And they're designed when they hit a certain point to have so much damage that they go, oop, time to go. And they kill themselves off and they recycle the good parts. That's what autophagy is. If they don't go away, and why don't they go away? Why doesn't that autophagy occur? Mostly because of genetics and diet and environment and, lacking, appropriate responses to this. So age in of itself induces a lack of autophagy, at least if you're not doing everything appropriately. So basically that if that's cell death doesn't occur, that's why the zombie term is perfect, right? These cells should be dead. They should have killed themselves off, just like dead people should die. And if they don't, they become zombies. And what do zombies do? Their goal is to take over the world because they want everybody else to be zombies. So they start killing everybody around them, turning them into zombies. That's exactly what these damaged cells do. They start.
So they're like an infective. They sort of infect all. It's like the bad apple in the barrel.
It's a little bit like why, who knows? But it's probably just this. It may have something to from in a kind of a protective response. When we're growing and developing, you want some autophagy. You don't want overgrowth of cells. You want some autophagy for cancer protection too, right? So basically, you don't want these cells to keep growing because that's going to also cause cancer. So there's always this balance in everything. So basically that autophagy process we now are linking to a lot of diseases. And it's funny that arthritis or joint pain or back pain, in all the talk about anti-aging medicine and all the longevity clinics, nobody really focuses on it, right? That seems to be kept separate. Everybody thinks about metabolic health and they think about brain health and they think about, cancer and things like that when we're doing, but they don't think about arthritis. And yet, if you look at one of the most debilitating things that happens to us as we age, it's a lack of being able to do anything we love anymore, right? My dad, who, lived to be 91, 92, he was a super fit guy. He was climbing mountains and skiing in his 80s. And then when his arthritis got so bad, he honestly and couldn't do anything anymore. It sort of was his downfall, right? He sort of started losing his desire to live.
Thing. Because when you're in pain and you're not gonna, have your quality of life.
Exactly. Like somebody like you and I who live a lot of our life based on, we love being active and doing things. when you take that away from somebody,
Yeah.
the quality of life really goes.
Yep.
So we keep focusing on these big bad diseases that, yes, will potentially kill you, but here's a disease that ultimately completely, and it's one of the most common causes of disability. It's way above heart disease and, and all these other diseases as a cause of disability. Even in young people, it's the number one leading cause of disability in people of working age.
Yeah.
So it's the main reason people get out of the workforce even.
And this
yet
is so preventable to a large degree, despite genetics and stuff. But our approach,
once it occurs, right? So that, like you said, you have no discs in your back. I have no cartilage in my knees, but we don't have pain because we've gotten our cell health to an optimal level where we don't have all these inflammatory things going on. So,
and I notice immediately, like if I have a couple of glasses of wine and eat something bad, and then the next day, without fail,
exactly.
I have more pain in my body. And so I've linked those two events together in my head, but most people don't, because they're living that way maybe all of the time, rather than on an occasion.
Don't have a good days.
Yeah. And so they just think that pain is normal, and that's just a part of the arthritis process, when actually, and having come from having a very painful back and, and in my case, doing too much running, causing too much inflammation and all of that. And now not having it, my God, my life quality is just so much better when I don't have to deal with that pain. And unfortunately, the sort of traditional approach is either surgery or arthroscopic, knee surgeries and things, or it's steroid either injections or steroids, taking them orally, which why is that not a good idea? And why, if we go through arthroscopic treatments and steroids, why are they not great?
Well, so let's talk about kind of traditional treatments. Because I come, my background, Lisa, is orthopedics, right?
Yeah.
I come from this traditional orthopedic background. I mean, it took me a long time to say, wow, what I'm doing is really,
not working,
not helping, right? But your orthopedic doctor doesn't want to hear that, right? They don't want to hear that their bread and butter, which is, steroid surgery, joint replacement, is not right. So let's look at, like, when you look, for instance, at steroid injections, steroid injections temporarily are going to reduce those inflammatory cytokines. You will feel better. But they also are going to reduce all of those anti-inflammatory cytokines that help you heal. So we know very well that steroids are a double-edged sword, and that we know that there's at least a dozen studies out there now that show, yes, they have some temporary benefit, with the long-term being that the disease will progress more rapidly. So, they're used as a temporizing measure, and in most orthopedists' mind, let's do them steroid injection. Ultimately, the goal is you're going to need a joint replacement in a year, right? And they'll tell people that, this will get you through until we do their joint replacement. And they wait until it's progressed, and they are actually helping it progress a little faster so they can get to their joint replacement. And, and that's their ultimate goal, because that's where the money is. That's
where the money is, doing replacements. And, sometimes it is necessary.
Can be helpful, right? I mean, if you've got end stage arthritis, it's a last resort, replacing the hip, replacing the knee can definitely be helpful. I'm not going to sort of say it's never something we want to use, but the goal would be, if we can start addressing this problem when we should be, which is when injuries start first occurring, just like all these diseases, then you shouldn't have to get to that stage where, so we know that steroid injections are a double-edged sword. Yes, they help temporarily, but they're progressing you further down that road. So then you look at, okay, what about what we do a lot here in the US, and you guys do a little bit less, is arthroscopic surgery, where somebody comes in with knee pain and they're like, your surgeon goes, well, you've got some damage to your cartilage. Let's just go in there and trim it up and, clean the joint up. Let's clean it up. And I always tell people, well, that'd be a lot like me going with my dementia to my, my neurologist, and them saying, let's just trim out those bad parts of your brain. I mean, or your heart rate. It makes zero sense. And yet somehow people think it makes sense in a joint to go clean out the damaged cartilage. Well, what we know is that arthroscopic surgery, again, may provide some temporary relief. It seems to actually maybe offer a little bit, but not much more rapidly progresses the arthritis. In fact, sometimes a very rapid decline. I just saw a patient last week who had a little tiny cartilage tear in her knee. My age, like 60 something, and she had a little tiny cartilage tear in her knee. And, when had surgery, oh my gosh, she so rapidly, you should see the MRI scans, really 3 months apart, went from a little tiny meniscal damage to full blown horrible knee. Because think about back what we just said. What did that sticking a scope in the knee, trimming up things, what did it do?
Caused inflammation.
Right. So now we just got all these pro-inflammatory cytokines escalated, started that whole cascade of events to damage more cartilage cells, which damage more cartilage cells. So it's just frankly dumb to think we can go do that. And study after study after study, there's just another one that just came out, shows that it is not helpul.
Yeah,
it's the number one surgery.
And it's still ignored. It's still done every day in every hospital. What about back fusions? Are they different?
Well, so let's look at back fusion. So basically, why are you doing a back fusion? Basically, the only time back fusion is a successful procedure for any kind of long-term benefit is if you have instability in the spine. So some people, the spine actually becomes unstable enough that when they're moving, the vertebrae are shifting back and forth. If I can stabilize that segment, I do help with their pain. But if people just have degenerative discs and you're treating them with a fusion, the overall success rate of that surgery for long term is about 10% of people are better. And it's a little unclear even why that many are better. Because again, have you treated the disease process?
Yeah.
No. And again, what have I done if I fuse L4-5? And you see this all the time. The people come back a year later and they're like, oh, now L3-4 looks bad. Let's use that one. And then L2-3. Because actually, again, even though that segment's fused, it has no motion and you're probably not going to have pain at that level. The disease process is occurring at every other level of the spine.
Yeah.
And now with this, there's a great study I always show, all my patients that came out last year that showed that degenerative disc disease is an inflammatory disease, very much so.
Yeah.
And they showed very high levels of interleukin-1 beta and interleukin-6 and something called nuclear factor kappa beta. And so, and if you in mice, if you blocked those and you stuck a big hole in the disc, nothing happened. So we know we have to treat those and not the disc itself. That's the end game. Treat the problem that's causing the disc damage. It's going on at every other level. It's also why degenerative disc disease, degenerative joint disease those patients have higher risks of cardiovascular disease.
Exactly. This is the other thing. Like this is it's a warning signal, isn't it?
Right.
Because I'm got my brother at the moment who's had a hip replacement, and now the other hip's going in his mind. That's logical progression, right? It's I've done this, and I'm like trying to get him to understand that this, and it's only moderate at the moment. We may be able to save you from having this, or at least delay this and have a lot less pain in the meantime if we did these XYZ, in which we're going to get to in a little bit. But it's a hard jump. It's a mechanical thing.
Right.
I've got mechanical damage from a mechanical thing. One hip was gone, so therefore the other is gone. And I'm like, actually, if we look at your, cardiovascular health, cholesterol, all of these things, you'll start to see that all of those processes, and this is just generally speaking now, all those aging processes are going on in the body elsewhere, and it's showing itself. And this is actually a big warning sign. It's like, when I have something bad and eat bad and drink bad or something, then I get more pain in the body, and that's a definite correlation. Then that's a wake-up call. And by the same token, when someone has this degeneration, it is a wake-up call to actually go, I need to step back and re-examine things like your diet, your supplement regime, your exercise regime, and all of these things. And how do I get my pro-inflammatory cytokines and chemokines and everything down? And how do I increase the anti-inflammatory? So I think that's, sorry. Yeah.
I mean, you're exactly on. Like, your brother's that classic patient, and they, and they keep getting reinforced by their orthopedist to say, oh, well, of course your other hip's going to go because now it's going to take more load. and then you see the knee go, and they're like, yeah, well, now that's because we altered the gait a little bit, so your knee's going to go.
It just
the number of
knocks
patients I see
on.
who go first hip, and then second hip, and then knee, and the next knee. And is this ever a wake up call that
No.
something else might be wrong? Honestly,
They just still think it's a mechanical thing from walking different or, going different. And it's a simplistic, it's a simplistic
it's
way.
not from a life well lived. It's not from overuse of the joints.
Otherwise I'm bugging and you're bugging long ago.
It's huge. And, I can look back now and say there's a lot of things I would have, done differently to not have my knees where they are right now. Right. You too, like, that for you was probably an overtraining phenomena. For me, probably, stress and, so my genetics and poor sleep and all the other things that I did, so there's a lot of pieces. And the problem is when we're young, we actually don't think that way, right?
Bulletproof.
Think, an injury, I'll get better, or I can do anything. I can not sleep. It's okay because I'll sleep when I'm old. And all those things. That's where we have to start educating people. We're really trying to get into the heads of these 20-year-olds and say, this process is starting when you're 20. Just like your brain diseases and your heart diseases and your cancers are. All those processes are starting in our 20s. I'm playing catch up to damage done. It'd be a lot better to prevent the damage in the first place. But again, like you and I, even though we have these completely worn out parts, why have we gotten our pain under control? It's because we fall in. And I, like you, man, if I eat gluten, my knees hurt like stink. If I, if I drink alcohol, if I eat sugar, those are all things that are, oddly enough, you still every now and then do it, right?
Because you're still human. Who has cravings?
Like, I don't know how our brains can continue to say, oh, this makes me feel really bad, but it tastes
makes
really
me feel good right now, and I'm stressed.
Yeah, we're still driven a lot by that momentary happiness somehow. But,
It's a daily battle for all of us.
It's a daily battle, right? But the more the more you get trained into it, eventually you start getting compelled. But it's really hard to convince the 20-year-old that that injury you had is not going to just get better unless you do this and this and this. So I think there's the big lesson is that this is a disease we have to start addressing at young age when somebody has their first injury and looking at things, and we have to start addressing the people now, like myself, who are older and have arthritis, to help their overall well-being so they don't get progressive worsening of not just other joints, but every other body part. It's just so strange to me that the joints have been excluded. I mean, think about all the doctors you listen to who are the functional medicine, biohackers, all the people, I don't even those big biohackers,
no one talks about
talking
arthritis.
About joints, right? No. They don't talk about joint pain as that, they somehow the joints have been separated out from the rest of their body, and we need to change that paradigm. There's a great article that came out of British Medical Journal last year. It said, is 2021 the year we rethink arthritis as an inflammatory disease? And I was hopeful, but it didn't. And well, this year, no. And I think the problem is, again, like, why, and I guess like every other disease, there is huge money.
Exactly.
And spinal fusions. Spinal fusion is $100,000 surgery. Also.
Wow, really? Wow.
There's a lot of money to both the surgeon, the hospital, and the people who are supplying the little screws and hardware to doing that fusion. Joint replacement is the same thing. The joint replacement is a huge industry. If we stop doing joint replacements, there's a
lot of money going out of this
companies,
system.
Right? There's companies that would be shut down. Not to mention, these total joint surgeons who, total joint surgeon, my other practice was making $1 million a year. I mean,
holy heck.
So there's very little desire.
And this is so
like cancer, right? Or,
how long is it? It's like 12 weeks with mum's cancer journey, and now we've got no sign of cancer in the MRI. Under the resolution of the MRI, I don't know, but right now there's no tumors showing up. And this is like the same battle with the metabolic approach to cancer. It's not going to make anybody rich. It's not, this is just pervasive. I mean, we've had this conversation, and and it's not just evil people. There are those. But it's also just the way the system's growing over time. But what that means for you as the individual listening to this is has to go, okay, when I go to the butcher, he's going to, give me meat. When I go to the surgeon, they're going to want to do surgery. That's what they know. That's what they're taught. And so don't expect a different recommendation. So therefore, you as the consumer of all of this, or the patient, has to go, okay, where is the actual research at, which we can access now? And you can go and read the British Medical Journal or PubMed or whatever and find out all these things. Not everybody knows how to do that, I know. But you can access that information, and you have to take that proactive step rather than going somewhere where that's what they do, that is the standard of care, and you're going to be the next in line to get the standard of care, when actually the science has moved on 20 years from here, but it's not getting through to there because money, education, whatever the case may be, standard of care rules, blah, blah. I'm so big on that because I want people to understand the mechanisms that are at play in this whole medical world. So you have to actually take steps to, and, like I come to you, I have mum under you, that costs me money, and it costs me more than going to my local doctor. And I get better than local doctor results. It's just the way it is, because you're not getting funded to see me by the government or anything. So I have to pay for that privately. And I'm, very lucky that we've been able to do that. But you have to understand that that's what you're in for. And therefore you need to sort of prepare for that as well. I mean, getting off into a financial thing.
Yeah. But, I mean, that's always, that is a really hard thing. It was, it's always a hard thing in our business that people, especially here, but for you guys too, people are really caught in the, well, I've got this approach that somebody's going to pay for me to get this,
that's free, or
this approach that I have to actually pay to understand this, and maybe pay for some of the treatments because they're out of the realm of traditional practice. And so
it's frustrating.
We put, people spend so much money on things like their cars and their homes, and literally instead of their health. And it's funny, somebody just posted something about that, on an Instagram post, and I responded. I said, the number of patients who I walk in my office and they go, oh, well, that's way too expensive for me to do. And then I see them walk out into their,
Lexus or something,
their Lexus car. It's crazy. I'm going to put my money on my health because, as I think one of my Instagram followers, responded, my grandma always used to say, there's no banks in the cemetery. We can't. People, once you get sick, like I have cancer patients who will give their life savings to get well. So the problem is, once you get sick, right, it's a little bit more compelling, especially if you've exhausted traditional options. Then people are going to spend the money, right? But to compel people who feel like, well, I can get this paid for, and your treatment's going to cost me money. I don't know how we get people out of that mindset. I know that health is as important a commodity as anything you're going to spend money on. Probably. And
prevention is even harder because people don't understand. Right. So the prevention thing, again, the argument with my brother, can you buy these supplements that I want you to take in order to protect your hip so that you don't have like, oh, that's too expensive, I can't afford that. Right. And I'm like,
and they are. You're right. I mean, these things we use, a lot of these supplements are really expensive, right? I mean, a lot of these supplements are, you're like, Jesus, they are super expensive, or these treatments like hyperbaric or things like that. They are expensive treatments. I mean, you're like to have hyperbaric, but if you don't, you can spend thousands of dollars a week sometimes for hyperbaric therapy, and so it is really, really hard.
Yeah, it is.
I don't know how. That every day. It's so funny. The plastic surgeons are doing fine, however. People are more than willing to spend that money on their facelifts and things like that. Yet internally, to feel better, they're not. So we do have to kind of change that paradigm. I think it's slowly occurring, but that is a tough road.
Yeah, for me, it's just logical. Having been there and having seen the devastation of a terrible illness that I could have, prevented if I look back, 10 years before Mum had the aneurysm, what would I have saved myself? Not money, stress, time, looking after her, all the fear, the blah, blah, blah. Why didn't I go back 10 years ago and, start getting her into stuff back then, or start educating myself?
Know it, right? I mean, so
it wasn't urgent, was it?
Well, and also the amazing thing about this business, as you know, is it is changing rapidly.
Yeah.
I mean, the new things that are available, that you have to be up on this literature, up on this education. I mean, I spend a lot of money every year just to go learn, because it is a field that is right, it's changing so rapidly that you have to stay up on it.
Yeah.
And so, so it is another hard thing, is that we will look back in another year from now and say, wow, we should have been doing that 5 years ago. So we are in this realm of this field that's growing exponentially in our understanding of how to cure disease and cure aging, which is every one of these diseases, right? All these diseases come down to curing aging, which is all this immune inflammatory process that causes our aging of our cells.
Yeah. And so if we go back to the arthritis stuff, what are some of the practical things? What are some of the supplements we can take? What are some of the diet recommendations that you would make? How can we get this inflammation and inflammaging process and the senescent cells gone and the autophagy happening? What's our best plan of attack if you have someone listening out there who needs a joint replacement or has arthritis?
Take it down to, okay, like I said, first thing is you've got to balance that anti-inflammatory, pro-inflammatory. You've got to get down those pro-inflammatory cytokines. You have to reduce some of these enzymes. So when our body's in a joint, or any body part really, has these very high inflammatory cytokines, these inflammatory proteins, one of the things they do is they accelerate these enzymes, something called metallomatrix protein 3 and these ADAM enzymes. I always like to describe these enzymes as scrubbing, like you have a spot on your wall, and now you're like, oh, I should get rid of that spot. And you start scrubbing the wall so hard that the spot's gone, but so is the wall.
Yeah.
So that's what happens with these enzymes. They get upregulated, but they just keep going. So now they didn't just get rid of the damage; they actually got rid of the joint, the cartilage, all the tissue. So you've got to get rid of the pro-inflammatory cytokines. You've got to reduce these degradative enzymes. And that's a tricky thing. Then you have to repair the mitochondria, get autophagy back, and then you can do things to actually repair the joint. All you guys who are going and getting stem cells and things like that, if I just put a great picture up on my Instagram that came up that showed the senescent cell and a stem cell, and the senescent cell just spewing out these proteins that were damaging the stem cell. So if I stick stem cells into your joint, it's full of these damaged chondrocytes, it's just going to damage it.
Yeah, it would be great if they were gone. So you would do it the other way around, to get rid of it. And then
get rid of the inflammation first, and then you can do reparative things like stem cells or platelets or other things to actually repair the cartilage. So one of the, and this is actually a drug we actually stole from Australia called Pentosan Polysulfate. And this is a pharmaceutical, so you do need a prescription for it. But
I'm trying to
find
it.
Cool. Yeah, it's a very cool pharmaceutical, and we do actually, we can send it to people who are like in other countries. So it is available. You have to have it sent to us, and then we can send it. But basically, Pentosan's very cool. It's what we call a repurposed drug, meaning it's an approved drug just for something else. And so they started exploring it in Australia. A company called Paradigm makes it, that they looked at all its properties, and actually they were utilizing it as under a lot of investigation for some viral therapies as well, like Ross River virus and some really damaging viral therapies, and may actually be useful for COVID and things like that, because it does have some very good antiviral properties, because viruses initiate this same inflammatory response. But
they do.
What they found is that it kind of addressed every one of those pieces we were talking about. So it reduces what's called interleukin-1 beta and TNF-alpha and interleukin-6. Those are all the pro-inflammatory cytokines. It's one of the few agents we have that actually down-regulates those bad scrubbing bubbles, over-scrubbing enzymes, the metallomatrix protein 3. So it down-regulates those. And then the other thing we see happen with joints and why they hurt so much in discs is you see upregulation of these messenger RNAs for something called neural growth factors. And those get upregulated, we actually see a lot of pain. That's that kind of pain you get with joints. Like it doesn't just hurt when you're using it, it hurts all the time. So it's also been shown to regulate the mRNAs for this neural growth factor. So it actually kind of treats every aspect that's causing the degenerative disc pain or the degenerative joint pain or just joint pain in general. So we'll actually utilize this drug in a lot of our people who have an injury to really allow them to heal really well. So Pentosan was actually shown, even after just 6 weeks of use, if you follow those people for a year, they actually continued to have benefits. So not just
And this is
temporarily
an injection, isn't it?
it's
Rather
an injection
than,
you have to give yourself,
unfortunately.
subcutaneous injection. Yeah. So you have to,
So
much like a
sub-Q,
lot of
not
peptide
much.
therapies, it's just a sub-Q injection. So it's something we could
wow.
train people to do themselves.
Yeah.
Now I will tell you,
easy.
people like me, so I stay on Pentosan a little bit all the time.
Right.
It appears that when I go off of it, my body does like to go back into, from wherever my genetics are. Even if I'm living life perfectly, my body goes back into a little this inflammatory state, and I start feeling my knees get a little bit achy again. So I stay on a small bit of it all the time. But some people who have probably less disease or better genetics, we can do a little course of it, and they do really well. So it varies, but it is a great. Honestly, it's been touted as maybe a cure for arthritis, and it may well be that it does have that significant benefit, especially if you can start it at an earlier stage. A lot of us are again starting at a later stage. So
that's great.
It's a very cool. It's a very it's really kind of amazing. So it's actually treating all the pro-inflammatory mediators. It's helping any kind of bone edema. And it actually has some really good vascular properties too. So it actually helps some of the vascular changes. So it has, we're using a little bit antiviral protection. We're using it, sometimes for some of our autoimmune patients. So it has some other benefits. People, the post-COVID stuff where there's some vascular things going on, we'll use it a lot in those patients too.
What about neuropathy, from statins and things like that, or painful feet, and that sort of?
I've not really tried it much in neuropathy. That's an interesting concept, because it may well be that regulation of those NGF, the neural growth factors, it may actually be very beneficial in those cases. So I haven't really experimented with that, but it might be something
it's just connecting the dots.
It might be, it might be helpful in that realm, because it does have so many, working on some of these anti-inflammatory things. But what about simple things that you can kind of just, get on your own? Well, number one, making sure that you have your nutrients optimized, right? You got to have enough vitamin D on board. So you need your vitamin D levels to be 70 to 110. Optimal vitamin D, we know, is really important for joint health, along with vitamin C, zinc. Those are all K2. Those are all kind of critical players. So don't neglect simple micronutrients, which to you and I just, it's like, well, of course.
Yeah, just
but
take them every
a lot
day.
of people that they're not really thinking along that lines. And so
and they think they get it from their diet, and that's pretty. That was back in the day, but not with our diet.
At some point when you were growing food in perfect soil, now, even if you're growing your own food, it's very hard to find soil that's nutrient rich. So so not that available. So you've got to make sure you're taking some supplements. Almost everybody, unless you're out in the sun all the time, needs extra vitamin D. A lot of people need extra vitamin C, zinc, K2. Those are all just kind of givens for us. One of my favorite supplements, honestly, and we use it in our cancer patients too, is EGCGs, or epigallocatechins, which are EGCG,
green tea stuff.
Green tea, right? So it's what's in green tea. And you have to drink a lot of green tea, so it's probably better taken as a supplement. But the EGCG or epigallocatechins have so many benefits. Number one, if you're into muscle building and fat loss, they actually block myostatin. So they actually help with muscle building. So you can actually have somebody put on muscle, even if they're not exercising, just by using enough green tea extracts or the EGCGs. And you have to get to like 1,000 twice a day, but you can actually just put on muscle. So, and if you're exercising along with that, that can be really helpful. So just from that perspective. Now, why is that beneficial to arthritis if you put on more muscle? Well, muscle, remember, is an organ. It's just like your liver or your, it actually produces
endocrine active,
and it's an endocrine organ, and it produces something called myokines. And myokines have been shown to actually have a very beneficial effect for joints. So people who become sarcopenic, who lose muscle, have more joint arthritis. And we've always said, oh, that's because they don't have as much support of the joint. It's probably because they don't have the myokine release to actually to actually stimulate activity. And that may be why some of our people who you can't get to exercise, for instance, are just too frail, or they're bedridden for some other reason, that using muscle stim techniques where you're just using electrical stimulation of muscle, so the muscle contracts, even if you can't do it yourself, like you're too sick, you're too far along in a disease process. We can actually stimulate myokines just by doing electrical stimulation of muscles. And that can help joint health just by doing that kind of stuff. So using electric stimulation units, and there's a lot on the market, can be beneficial to induce these really, beneficial myokine release, or just even doing static contraction, like just sitting there and contracting your muscle like this for 3 seconds every hour, releases myokines.
Serious guns you've got there.
So you can do something like that actually, it's super simple for your patients to do, right?
Yeah.
And release myokine. So again, more muscle, less joint pain. Now, again, epigallocatechins will help build more muscle, but they also, we talked about interleukin-1 beta. They lower interleukin-1 beta. They lower interleukin-6. They lower oxidative stress. So they're actually very, very aggressively treating all the things that involve, probably not the degradative enzymes, but all those other pieces that are involved in terms of arthritis. But for cancer too, these same processes are all going on with cancer.
Yeah.
So we know that high dose epigallocatechins,
She's on it.
right, that using the high dose epigallocatechins in cancer can be, it's one of the few things that maybe if you could get the dose high enough and more sustained, that could be curative to cancers. So so they have huge benefits. So
any downside to those,
if you get
liver,
super high dose, it can be liver toxic. So if you get very high dose, you have to watch liver functions.
Yeah.
And that's probably if you get above 2,000 a day, you have to at least keep an eye on liver functions. Probably at least. So we have our patients do 500 twice a day. I will go higher than that on some of my patients, but I will follow liver functions if I go higher. I have to say I've not seen any of my patients get elevated liver functions, but it's been shown that it can become liver toxic at high enough doses. Sometimes we'll use, for our cancer patients, we'll use a rectal suppository to bypass the liver to get very high doses in. So we'll actually have them do as a rectal suppository. So there's a company that makes a rectal suppository of epigallocatechins that when you really need to dose it higher, you can utilize.
Without damaging your liver,
without damaging the liver as much,
Wow.
So again, it's kind of the epigallocatechins reduce the inflammation, and it's been shown that what happens is that you actually stop the degradative process. So wherever you are right now, you halt the progression of the disease. Now, are you going to grow new cartilage? Maybe not, but we stop that progression, we stop the inflammation, and hence stop the pain. Again, you can have no cartilage and no pain, or no discs and no pain. The pain is an inflammatory sign.
Wow.
So,
okay. So that's couple.
So that's treating the the inflammation. Pentosan kind of again treating everything. So now remember we had to work on that mitochondria or autophagy process, right? So one of my sort of favorite go-to supplements for that is spermidine.
Yep.
Spermidine, which is what's called a polyamine, and our gut, we naturally make polyamines. We make less as we age, so levels decline as we age. It's available in foods, but again, because it actually comes from a bacteria that in certain foods, and so foods that have been on the shelf or transported or not grown in perfect environments, it's much, even people always say, oh, there's so much spermidine in this food. When we actually have looked at the amount of spermidine that's in the traditional food you buy in the grocery store, there's very little, even if it's a high polyamine food. So really you have to take it as a supplement to make sure you're getting it, and what's been shown is that spermidine as actually works in a couple of places. Number one, remember we talked about the importance of autophagy. Spermidine is an autophagy inducing agent.
Yep.
So basically it gets rid of these, these damaged cells. So that's, so that's huge because we now have linked autophagy to arthritis. But it also works on interleukin-6, interleukin-1 beta. So it's working on that piece as well. Very interesting. They did a mouse study. I think it was 2021. It was recently, it was last year. They did a mouse study where they compared using high dose spermidine. So we're talking about 6 micrograms or so a day versus steroids for joint pain. It was better than steroids for joint
Wow.
pain. So it reduced inflammation much more than steroids for joint pain, with the added benefit that you're actually protecting
So
the
good
joint,
for you.
not
Yep.
worsening the joint, right?
Mhm.
And at the same time, protecting your brain, protecting your heart. We know that
It's just good
you
for
know,
everything.
spermidine is great for brain health. So again, all these diseases overlap, right? So spermidine, study that came out of, I think it was Italy last year, that showed that you actually were able to not just stop the progression, which it did do, but even show repair or improvement in cartilage cells. So it may actually be a little bit of with that high polyamine, a little bit reparative as well. So again, autophagy inducing,
Yep.
anti-inflammatory. So look at the combination of, those things together, and, and that's huge.
I actually have
if it's put
Spermidine
together, right?
in my shop. I've got a few little, I got a small amount, and it's very expensive, unfortunately.
It's
But
super
yeah,
expensive.
yeah,
It's super expensive. And that's, again, it is, like you said, Lisa, it's one of the hard things. So, when you're looking at these supplements, what is the most important? And what I'll do lots of times with spermidine is I won't have people just stay on it forever. I'll have them do a pretty high dose
Yep.
for a few months. Epigallocatechins are not horribly expensive, so you
No.
can kind of go to that.
yeah.
And then, the other supplement, which a lot of people haven't heard a lot about, is, actually a sugar called Trehalose or Trehalose.
Yeah, Trehalose. I've got that
Trehalose
now.
is kind
after
of
our last
amazing, right?
Yeah,
I mean,
yeah.
And so, when we look at Trehalose, it really impacts oxidative stress, and it helps sort of clean up of the cells as well. So it's, and here's a supplement. It's basically a sugar. It's 2 glucose molecules, but has 0 glycemic impact. And in fact, it actually helps with our diabetics to keep blood glucose under control. That in of itself is probably helpful to joint pain as well. But it's been really looked at for neurodegenerative diseases. In fact, a drug form of it, a very expensive drug form of it, is being investigated for both MS and ALS because it has neuroreparative, but it appears to also have joint reparative.
Wow.
So it was a great study that they did out of China in mice, where they went and they damaged the cartilage to the joint, and they put one mouse on Trehalose, the other mice not. And if the mouse was taking Trehalose, they saw 0, even if they went and pounded holes in the cartilage, they saw 0 progression into arthritis.
Wow.
So here's something that's super joint protective
And
for those of you who
quite
are
cheap,
who
yeah.
have injuries or
Yeah.
are doing kind of repetitive trauma activities, right? Like running super high levels or doing sports that are really, hard on joints. Here's something that you can do. So I use Trehalose basically as a sweetener for everything. I put it in, I put it in my coffee.
Yep, me too.
I cook with it, right? It's one of those things where more is better, and it's benign, it has 0 bad sides to it. It's a sugar, which is nice because you can substitute, any sweetener.
And yet it's got no
probably-
glycemic
It's got all
impact.
these huge, 0 glycemic impact. In fact, it controls blood glucose release.
Wow.
So, I have a really just genetically, like my mom was very fit and active but she was a type 2 diabetic, even eating healthy. I was always raised eating healthy and exercising. She was a type 2 diabetic, which ultimately I think probably was her demise to her brain. And I have a similarly hard to control glucose. Like, I use my CGM. It's just hard to control glucose. And it's interesting how much of a difference Trehalose makes for me in terms of just keeping my blood glucose rock solid stable if I use it really consistently. I have a patient who is a great cook. She makes me cookies with it. Here's a cookie that you can eat. She just makes it with, it's gluten-free, really healthy cookie that's sweetened with nothing but Trehalose, so I can eat the cookie and have my blood glucose actually go down.
Wow. Get some of that. I mean, I'm on Trehalose since I listened to one of your lectures, and I'm like, okay, getting that, and Mum's on that too now, and I have it sort of 3 times a day, and it's it's
exactly,
like
3 times a day. It's
all upsides,
it's sort of kind of all upsides, exactly. So and then there's always things like some peptide therapies too.
Yep.
Collagen peptides, simple, inexpensive, but collagen peptides, and people are always like, well, collagen peptides aren't all that beneficial. They actually are. Mixed with some vitamin C, you do see actually benefits to cartilage, to cartilage cells. So
this is a drink one or an injection one?
Like you can do a powdered collagen drink. Just put the powdered collagen in your drink, and do it. We like a collagen peptide called Fortigel, which is a sort of trademarked collagen peptide. And there's a couple of brands that contain Fortigel. but I would
Okay.
look for the Fortigel. It's a trademark type of collagen peptide. And there's a
Okay.
couple of brands. If you Google Fortigel, there's a couple of brands that use Fortigel. And ideally, if it has some vitamin C in it too, that combination of vitamin C and the Fortigel together, they did a study with it, plus double-blind, placebo-controlled study with just collagen, and ranked knee pain, walking distance, and universally 90% of people did better just with collagen. So that's a really simple, easy thing too, that you can sort of add a little scoop of a collagen peptide, do that every single day. And then other kind of more expensive, aggressive peptides like BPC, or body protective compound 157.
157, yeah.
BPC 157, especially combined with a thymic peptide called thymosin beta 4. That combination is also very helpful for joint regeneration. But I would tell you that those are add-ons. Those people who are just going and trying to treat their arthritis with these expensive peptides are probably neglecting the inflammatory piece a lot, and they're trying to get into this reparative mode when they haven't really addressed all the other problems going on.
Yep.
Right. Yeah. So again, get the inflammatory stuff under control, and then you can kind of add those in for benefit and for regeneration as at that point. So if I get, our patients, we're going to always get all this inflammatory stuff under control. Before I do any, and I do a lot of regenerative therapies on my patients, but those patients who come in and want me to just, do stem cells, like it's stupid. It's a waste of your money until we get all this other stuff under control.
Yeah.
But how often do you see that? There are so many stem cell regenerative orthopedic places around, and and people are going there and they spent $5,000, $10,000. I saw a patient who literally spent $30,000 for this sort of all over stem cell. I mean, literally, this doctor injected stem cells into almost every joint in her body.
Wow.
And I'm like, okay, well, when every joint in your body was bad, did you think maybe there was something else going on?
Something, systemic. Hello.
But
again, go back. I think everything, that's what I've learned from you and from my studies over the last few years, is go back up the tree, and then you'll hit all of the diseases.
Right.
Mitochondria, inflammation.
It's all the same disease.
Yeah.
What we know is this inflammaging process, and it's affecting. You can go, every single disease is overaggressive pro-inflammatory cytokines, disruption in mitochondrial function, disruption in autophagy. Every single disease is aging, and so and the immune system goes awry. It's a dysfunction of our immune system, and our immune system goes awry for a lot of reasons. One is just age in of itself creates, but that's a result of viral exposures, for instance, right? That you get
viruses
exposed,
make you
Epstein-Barr virus or COVID or CMV or herpes viruses. We've all been exposed to these viruses, which stress our immune system. A lot of them stick around, but even those exposures, it's like Epstein-Barr virus, very linked to lymphomas and leukemia.
Yep, that's why Mum's got
why, it. Right? Because and yet
got the EBV.
we're like, oh, everybody gets Epstein-Barr virus. Well, sometimes it becomes sort of a latent virus that's continuing to create problems.
Yeah.
Or we've linked herpes simplex virus 6 to dementias. These viruses are not just benign entities. So we need to get more aggressive at helping the immune system, focusing on eradicating viruses, and getting the immune system as healthy as possible to fight cancers and all these other diseases.
So it's like putting antivirals into the mix occasionally, or
I do. I use a fair number of antivirals, honestly.
Just to make sure we're not.
Right. I think there's very little downside sometimes. Exactly. If you've got these latent viruses, and we'll run viral scans on people a lot too, but if you've got these latent viruses that are sitting around doing, stressing our immune systems, it's one of the big worries with COVID is that it doesn't just go away. The spike protein doesn't just go away. So it's continuing to create this, this response.
Ongoing. So what sort of antivirals are there, and are there any natural ones, and what couple of the drugs that you might ask your doctor for?
Well, so epigallocatechin has some antiviral properties. It's where the Pentosan is nice because it has the antiviral properties. Things like curcumin has some nice antiviral properties as well. So those are kind of natural ways. Honestly, I will do a fair amount of using valcyclovir in people because it's sort of very safe. We use it for primarily for herpes virus, but it actually has, if you look at its viral spectrum, it actually has some benefits across the board. Even with Epstein-Barr, has some antiviral benefits. So I'll put a lot of my patients on an extended course of valcyclovir if they have these immune systems. There's little things we can look for in just a complete blood count, for instance, that say, yeah, this is a stressed immune system. The lymphocytes are low, the neutrophils are high, the monocytes are high. Those are all things that say, we really have a stressed immune system. And we do have a kind of a low threshold to put some of those patients on viral therapies. Again, the hope would be we could find some great antiviral that treats all these viruses, but probably that's,
dreaming. Yeah.
That's dreaming. Yeah. But again, that's where Pentosan, if you start looking at,
Pentosan,
it's really hard to treat viruses.
Yep.
We don't have Ross River virus, but I think you guys do. Australia does, which is a virus that when you get induced to it, initiates this horrible progressive arthritis. So does dengue fever, those kinds of things.
Yeah.
Great. So there's a link between viruses and arthritis as well. So I do have a kind of a low threshold to use antiviral agents to help the immune system a little bit, right?
So you don't develop these things later on.
Yeah. And you've got to look at hormones too, right? Because hormones have huge immune modulating properties. Testosterone is very immune modulating. Progesterone is very immune modulating. So that's another reason as we age, our immune systems start to go awry, because we don't have hormones anymore unless you're replacing them. Yeah. So that has to be put into the mix too if we're going to do that. So, this whole, again, be it cancer, be it metabolic disease, be it cardiovascular disease, be it neurologic, arthritis, they are all the same disease. And you've got to get the immune system healthy as possible. You have to stop oxidative stress, and again, all the stuff you preach all the time with diet and appropriate exercise, not too much exercise, right?
Not too much, yeah.
That stresses the immune system.
Yeah. It's just keeping that balance. And what about some of the growth factors? A growth factor is good. So like if you've got a lot of human growth hormone, or you're if you've got lots of testosterone and lots of what's the other one? Insulin-like growth factors and things, are they going to impact the joint negatively when you're growing all the time? Like this is where the autophagy piece comes in. No.
So we used to, back in the old days, actually, there was a lot of studies injecting growth hormone in joints, and it was super, super beneficial to the joint to inject growth hormone to the joint. There was a doctor who was doing a ton of it, and that became really hard to get growth hormone. But we will still actually inject IGF sometimes into joints, intra-articularly, with significant benefits in helping people with inflammation. So IGF is beneficial. There's, like all growth factors, there's a balance. We know that, for instance, too much transforming growth factor, TGF, beta, is not good, right? So there's kind of this balance. You need to have sort of like too much is bad, too little is bad. So that's what you always have to look at when you're inducing things. But when you look at growth factors, it's one of the ways stem cells are working. They contain tons of growth factors. They're modulatory in that they usually don't overshoot. So again, if you overhit IGF, if you push remember, growth hormone induces insulin-like growth factor. That's how we get IGF. Is growth hormone tells our liver to produce IGF. IGF goes everywhere. It has great properties. It's immune modulating. It helps with pain. It helps with deep sleep. But if you get too high, too much growth, it's bad. Then you lead to cancers and things like that. So there's always this balance.
There's always this Goldilocks thing.
Right. There's always this kind of like not doing too much of something to get that balance. And, and that's where you have to be a little careful with just, like what some of the people who are doing just massive growth hormone injections and things like that. Using peptides to modulate growth hormone can be a lot safer, because you usually aren't going to get these huge escalating levels. You get this nice kind of balance. And then what you want for most growth factors is you want them to kind of go up and down. You don't want them continuously turned on. So, there is some research actually showing using, blockers of some growth factors can be helpful in arthritis, when they're very upregulated. So it really is this kind of, for those of you who are doing, like saying, I'm just going to keep taking more CJC and ipamorelin, which are increasing, growth hormone release and increasing IGF. Well, you want to make sure that, there is a too much, and what's usually best is to kind of cycle things, bringing them up, bringing them down, bringing them up, bringing them down. That's why, fasting really lowers IGF, right? So it's not really the really low IGF that's beneficial. It's the rebound after you stop fasting that you get this rebound IGF. That's actually where the benefit of repair comes from, is the refeed after fasting. So fasting induces autophagy, which is great, but it's not really particularly beneficial for regeneration. What's beneficial for regeneration is the rebound when you refeed. That's why the refeed to fasting is as important as the fast itself.
Wow.
So those are all,
but fasting is another big piece in which we didn't cover. It is an important part of either intermittent fasting or longer fast, if under the guidance of your doctor if you're doing a longer one. But it can be very beneficial to clear out these old senescent cells, these zombie cells, and start this process. And then there are also senolytics, which we can put in the mix too.
Right. True. Yeah. So, fasting, cheapest way to induce autophagy. You look at things like spermidine.
Yeah,
pricey. Not eating is actually, so spermidine is a fasting mimetic. It actually tricks your body into thinking you're fasting in a sense. But it's a lot cheaper to just not eat, right? That's actually less expensive than anything you can do, right? But it's also, it's tough, right? It's tough for a lot of people to fast. And again, one of the questions is, how long do you truly have to fast? We don't know the answer to that. Definitely, I try and get all my patients to at least time restrict their eating, because we know that has benefit. To eat within a smaller window has benefits, And then you're right, we use a lot of senolytic agents too, like rapamycin, because, rapamycin's a drug. It's an old chemotherapeutic drug, but it's actually not a great chemotherapeutic agent, but it's a very good immune modulating agent. And we know that rapamycin induces autophagy. It extends lifespan in every mammalian species. But
how does rapamycin be? Because I've always heard, you don't go rapamycin because it's immune, can damage your immune system. Not the case?
Not the case. It's the unfortunate sort of reputation rapamycin got because it started as a chemotherapeutic agent.
Yeah.
But if it's used in smaller amounts and not on a regular basis, it's immune modulating. It's not immunosuppressive. And again, remember, you don't stay on rapamycin continuously. You use it for a short period. We'll do 1 day a week. Basically, you'll take rapamycin just 1 day out of every week. Or some people will do a protocol where they do 1 week out of every month. Mikhail Blagoslani, who's probably the best researcher and the most knowledgeable person who's out of Russia, on rapamycin. He sort of believes in a little higher dose for like a week at a time. Mm-hmm. We're a little more conservative with it, but we do one day a week out of every, or 1 day out of every week, just a small dose. So you use it basically because the goal, again, you don't want to keep suppressing. We want to, to me, it's like cleaning house, right? If you don't ever accumulate any stuff, you're probably not living very well. So you're going to accumulate some stuff, but then you got to get rid of it, or you become a hoarder. Yeah. So that's what rapamycin does. It's like clean out. Okay, now I can regrow a little, clean out. So basically, like what we do a lot of is just 1 day a week, and rapamycin has some huge benefits. In we know from a longevity perspective, it may be one of the the best longevity drugs we have. But there's some great studies on it with arthritis. There's some great studies on it from cardiovascular and brain. So again, all those age-related diseases. So I will lots of times, and again, there's little things I'll look at in people's labs that will cue me in to say, hey, this is a person who I have to get more aggressive with autophagy, and I'll use things like rapamycin. So rapamycin is probably the penultimate senolytic agent that's out there. And again, the studies are going on right now for humans. Humans are hard because we live a long time, so it's much easier to study other animals. But the dog studies are really compelling. I mean, I have more patients who are buying rapamycin for their dogs than themselves. Everybody wants their dogs to live forever.
I want some rapamycin.
But it's the dog studies are pretty compelling. These dogs are living a third longer than other dogs, so it's, there's not a mammalian species that has not responded to rapamycin. So
does it work with against cancer, or is it anti-cancer, or is it sort of
it definitely has some anti-cancer properties, definitly.
All right, we need some for mum, please. Can you give me some for mum?
I mean, it's certainly, again, it's one of those things where the research is ongoing. We can't we don't have the definitive. I think the hardest thing to know is what is the right dose. I don't think that there's a question that it has benefits from longevity. I think the question is, are we doing enough? We tend to kind of err to the side of conservative, and we're basing our stuff off some of the animal studies. and maybe what we're doing is not enough.
It's too low enough.
We're going pretty conservative on it, but the research is compelling, and it's expanding on all the benefits of it. It really is pretty huge. And probably, Blagoslani says you should start at around age 25. Honestly, you should start it pretty young, because that's when you actually start accumulating damage, right? So could we actually, if we started everybody, the goal is going to be, honestly, Lisa, is that the problem is that people who are listening to us tend to be 40s plus, right?
Yeah.
And if we need to start getting
we need to hurry up
20-year-olds, right? We need to get the 20-year-olds to start thinking this way. It's funny, because my kids are I have 5 kids, but I've got 3 now in their 20s, and they're very much thinking along this line, but and they're trying to sort of teach their friends. My daughter, who's like 26, is trying to put together a podcast for that younger group.
Wow.
Because they're not they're not listening to you and I very much, right?
No.
20-year-old.
They never do. And Metformin is another one that I'm like swear by for a lot.
I forgot Metformin, but Metformin has some really interesting studies in arthritis too. Very compelling studies in arthritis as well. So it's not just in its senolytic properties, but directly on some of its effect actually on cartilage. So the studies on Metformin as an anti-arthritic drug were super interesting. So that's another again, very safe drug that has cardiovascular protection. Again, overlap, like renal protection, cancer protection, obesity protection. The big question in Metformin is does it impede muscle growth, right? That's the big, because it's an mTOR inhibitor. Is it is it too much muscle growth, right? And what I do with Metformin is I love Metformin. I take Metformin, but I cycle off of it, and I cycle off of it periodically. So I think the key there is maybe cycling it a little bit.
A bit like the rapamycin.
I know a lot of anti-aging docs that said, they kind of abandoned Metformin. I still think it's a really good drug and inexpensive. I'm on it.
I've got my family on it.
And I have not noticed really, I've got.
I've still got good muscles.
Right.
I haven't noticed that.
Not noticed a big.
I think you have to work harder, maybe.
Maybe. I mean, I think you do have to exercise a little bit more. I don't know. But I think its other health benefits are so incredibly compelling.
Yeah. And sugar, insulin resistance, and all that.
Keeping glucose controlled. So and it's you talk about inexpensive.
Yeah.
It's a very inexpensive drug. I think comparatively to things like like rapamycin and stuff. So I do. I mean, I include it when I give this talk on arthritis. There's a study that came out in 2020 that it said there was evidence that was significant benefit for osteoarthritis and preventing cartilage degeneration, but also in pain. It seemed to really help pain. So I think, again, here's if you go to your doc and you ask them for metformin for your joint pain, they're going to be like, you're crazy. But if you can compel a doctor to give you a prescription for it,
because you're pre-diabetic or something, you'll get it. But,
right.
Or if you've got a good doctor that's actually up on the research of metformin.
But if you Google metformin and osteoarthritis, there's a couple of great studies that come out that show it marked improvement. Like in mice, they would damage the joint. The mice would be limping around. They put them on metformin and they would stop limping. So we know it has these great anti-inflammatory benefits as well.
Yeah, I swear by it. I'm a big fan of that. Dr. Yurth, you've been so generous with your time today. Thank you. It's been a really interesting episode, and I think one that's going to help so many people, lots of athletes and lots of people dealing with arthritis and understanding those whole disease processes. And that's what we've talked about on a number of times on this podcast, is sort of going to get people to understand that whole go back up the ladder, go back up and see what's, causing
what's
all
wrong
of
with causing the problem, right? Not just treating the problem.
Yeah. It's just gold. And I would like people to go and check out Dr. Yurth's, Boulder Longevity Institute, if everyone wants to get under Dr. Yurth and her team there. Highly recommend it. I have mum under there, and that's been absolutely game-changing for me, for us. But also your longevity, your
yes, we have an academy, right?
Academy.
You guys be able to learn this stuff and listen to this stuff, because
this
as
is gold.
You guys, Lisa's teaching you. You guys have got to learn this stuff because your doctors don't know it. So that's what we realized we weren't making headway in trying to teach doctors. So we just go right to the consumer, to
the ones who need it.
So yeah,
Let's
so
go.
if you join bli.academy, if you go to bli.academy and you join that academy, there's some free content on there and there's some paid content, but we try and put together lectures every month to teach you more like we would teach doctors, sharing literature, those kinds of things. So not just, the problem with a lot of podcasters and people are doing this, and you not, but a lot of them are trying to sell something, right? A lot of times people are trying to sell things. We're trying to just give you science, not sell anything, and just share with you information and help you digest it. So go to that. I try on my Instagram at Dr. Yurth to share cool studies that come up, and just put little tidbits about them there so you guys can go look at the studies. But I try and keep an eye on cool studies that you guys can look at too. But the key is you guys have to learn like physicians should learn, which is from the science that's out there, and then make decisions based on that, not on somebody just saying, hey, this is a good thing to do.
And go and if you do listen to podcasts and things, go and do your own research. It's a bit like, because you have to actually go and look at the studies yourself, and even if you're not well versed in that, do a little bit more background, because for you it might not be appropriate, and this is why this is not medical advice, and this is only for education and entertainment, but it does put you on the right path to understanding stuff, and then going to your doctor and maybe taking some of the studies with you and going, hey, can I get this? Is this something that would help me? And it opens their minds too often. And that, that's slowly happening.
Now, I learned tons from my patients. Boy, my COVID long haul patients have taught me so much, because this is a tough disease, and a lot of them are doing tons of research, and they're like, hey, I just learned about this cool thing. Can we try it? I'm like, yeah, it looks really cool. And then I start learning about it, So I learned a ton from my patients. If you have a good doctor, they will appreciate you helping teach them.
Yes, and not the other way around.
Right?
It's really got to be this two-way co-learning. Co-learning is the word. Dr. Yurth, thank you so much today. We'll put all those links, and I hope that you're having a good time over there in Boulder. Everything okay now after?
I'm waiting for spring. It's still cold and snowy here, but
we're coming to the end of summer, so that's also good. All right. Thank you so much.
Bye, guys.